really nice complete summary. Try and put the IOTA in, because if you don't put it there, we may ask you to think about it. Remember the hierarchy. If you have an impacted tooth, that will rate above the overjet. So be clear to give us an IOTA. And if you give us it at the start, it's a really nice roundy one. We're not going to ask you that question. And again, like the Eastman question, put you on the spot and think, do it now, and then you won't have to think about it. Okay, take you through the extra-oral appearance. The first case you get, we will go back to first principles. Oh, using zero meridian, using vertical fifths and horizontal thirds, we will take you through all of that. We will not do that on the next three cases. Okay, because we know that we've already done that, so you will only get that on the first case. So in the second case, we'll probably say, what are the important points on this face? Big class 2, I can see from zero meridian, big class 2, incompetent lips and a gummy smile. Right, let's move on to the important stuff. Because we've already tested that. It's pointless us sitting there for another 5 minutes going, zero, yeah, we know zero meridian. Yeah, you've explained that to us already. So this is your first case. What do you think about the facial height? She's got barely competent lips. You can see she's got lip strain. She's got a reasonably consonant smile arc, but it's distorted by the crowding. The upper centerline is shifted to the right. She's got a class 2 skeletal profile with increased vertical proportions and decreased chin. Key features picked up in this case. Okay, we've got a flavour about this case.
Sorry, John, there's a question.
Yeah, question? It depends how many other things there are. You can't say complicated by everything. Yes, with the verticals, she's got a normal overline. So if somebody says you didn't mention the vertical, I say, well, yes, the vertical is an issue, but I think she's an extraction case, and she has a good solid overline from the start, so I didn't think that was a complicated feature. And actually, that will figure in my treatment plan later on. Okay, the vertical, so I will bring that back. It would be wrong to put that in, but it depends on the case. If you give me a list of 20 things that are complicated, I've forgotten what it is. I need to know the key things that make this case complicated. It's the overjet, the class 2, and the severe crowding and centerlines that make it more of a challenge. But by all means, you can put that in. Just be careful not to put too many things. We normally start with the lower arch. Some people just say, tell me about the intraoral appearance. I personally start with the lower arch again, systematically. Tell me the degree of crowding, the shape of the arch. Sometimes we argue. Some people don't seem to know what a V or a U is, but you know. U-shaped lower arch, severe crowding of approximately 7 to 8 millimeters with the centerline shifted to the right. The upper arch is maybe slightly more V-shaped. We've got severe crowding with buccal displacement of the canines. According to Profit, which says, then describe each of the crowding elements. The upper right lateral is slightly related in place. So the main features of note. You don't need to count the teeth unless there's something missing. If there is something missing, just say upper 7 to 7, excluding the upper right 3, which is impacted. Don't waste time going, this is an occlusal photograph of, yeah, that's not what this exam is. We want you to hone in, your specialist brain. We want you to hone in on the important features. Don't waste time typing, this is an OPG X-ray. I can't say it's an acceptable quality one. You don't need to go through the basics of that, just straight on to the key features. So tell me about this patient's occlusion. So we'll ask normally about the intra-arch relationships. Well, she's got a full unit class 2 molar and canine relationship on the right and the left sides. Both upper centerline and lower centerline are coincident with each other, with approximately 3 millimeters to the right of midline. Why might that be? Why do you think the centerlines are off to the right? Early loss of a deciduous tooth is most likely in the upper and lower arches. You can see that's where the majority of crowding is. So we might ask you about the etiology of your findings. Because you need to know why these things have happened. You can see the severity of the crowding for the right hand side. The most likely reason for this is an early loss of a deciduous tooth on the right that's been blocking out the canine, which is and then the intra-arch relation was a class 2 division 1. It's like, British Standards Institute, blah, blah. So we might say, what's the definition of that? Particularly if you've given us the wrong one. Now, in your models, in the printed models, you may have lower incisor edge was on the singular plateau. I understand there's a slightly increased overjet, but the British Standard Institute would say that that would be class 1, but I appreciate that maybe it's not class 2. Cephalometrically, again, how the features of the CEPH support our clinical findings, right? What to do. So if this came up as an A and B of -1, and I say the A and B is -1 and clearly this patient is class 3, we'd be going, oh, hang on a minute, that's not right, okay? Facially, this patient had a class 2 and the cephalometric analysis supports that with an A and B at 9 degrees. There isn't an Eastman correction here because SN maxillary plane is within the values of 5 to 12 we would normally accept. There is significant increase in the vertical proportion, the lower face line is increased, and there is an increased MM of 38 degrees. And that can be a problem with some of our treatment planning, but the patient does have a good overbite, and I think this is going to be an extraction case. So while it's a problem, and the way I'm managing the case, I think I'll be okay. So straight away, you're starting to link your treatment planning with your findings. Coming back to it. So their incisors at 97 degrees are quite proclined. CT for an MM at 38 degrees, I'd expect them to be much more upright, and the other labial segment is proclined, probably because of a bit of tract tendency that you can see. Okay. Again, make sure your aims match your plan, and then your treatment plan, and what options you do consider. Okay, so this is 13-year-old female. Now, this is a case that you wouldn't have treated the way I did, although I had a case exactly like this when I sat there. Just like this, big overjet, full unit class 2 severe growth. And I treated it in the way that I treated this patient. So a lot of people would say I would do a functional analysis. Okay? So I manage my anchorage, so the big anchorage issues here are a full unit class 2 molar, AP, and a big overjet, AP. Transversely, if I'm having any movement forwards in my lower arch, then I may have a transverse issue. If I don't do that transversely, we're okay apart from the centre lines. And both centre lines are off to one side, which is quite challenging to manage, because if I want to use asymmetric mechanics like class 2, class 3 elastics, they're in the wrong direction to help me. But I'm going to consider an extraction plan. And vertically, we have an increased vertical proportion, and we have an MM that's increased. However, our overbite is okay. The literature says that the most reasonable way of expecting stability of your overbite given the treatment is what your overbite is at the start. So with an extraction-based plan where I'm expecting some tipping back of the incisors, I'm not too worried about that. However, I would feel uncomfortable with certain functional appliances. Okay? So if you now start talking to me about twin block and start justifying it, don't think it's wrong. What are the issues with the twin block appliance? Well, it ramps the patient down. It increases the vertical. Now there are lots of functional appliances that don't do that. So you may consider an appliance like a fixed corrector or something like that to get some AP check. How did I treat this case? Lower left 4, lower right 5, to get my centre line right. And upper first 3 lines. So I use an asymmetric extraction pattern in the lower arch to correct the centre line. That makes my overjet worse, and my class 2 worse. And I treated it with 6s and 4s in the upper arch and head units. So a very difficult case. The full unit class 2, remember, if I've got crowding in an overjet, taking out 2 teeth, either resolves the crowding or the overjet. But once it's resolved the crowding, I've still got an overjet. So if you consider taking out 2 lower premolars, the canine relationship gets slightly worse, maybe even worse than the full unit class 2. You take out 2 first premolars to align your canines, you've now got a straight arch, but still a full unit class 2. You could then use some kind of fixed functional that would open the right vertically if you wanted. You could try distalization. Who thinks they could distalize molars at full unit? Do you think that's good in a high angle case? So again, if you said, and I'm going to distalize the full unit, I'd be saying, okay, how easy do you think that is? And if you go, oh, dead easy, I'd be thinking, fail. Because you can't easily distalize a molar at full unit. And it's very difficult for a patient. And when do you do it? At the start or later on? So I use some hypo headgear to control the vertical during the alignment, but not for but even TADs can't treat a full unit class 2 or get full unit distalization. And I don't want to distalize into the wedge to open this patient vertically. So I went for 6s and 4s with a staged extraction pattern to align my upper arch, keep my 6s. Then once I've got straight arches in class 2, at this time I put a TPA onto my 7s and then retracted my 5s into the 6 spaces. Did it work? We went from there. No, screws weren't available. This was 2002. First screws came to the UK in 2007. I did the second course ever in the UK and I've been using them ever since. So I would have put TAD TPA on my 7s. It wouldn't have changed my treatment plan, but my anchorage would have been different. I wouldn't have used headgear. I haven't used headgear since 2007. It's okay to use headgear if you think headgear is helpful. Putting headgear on 7s, is that easy? For a start, the bands don't have tubes on them. So you have to put a 6 tube on the 7, that doesn't fit. So again, if you start saying to me, oh yeah, I'm going to fit headgear to my 7s, I'll be thinking, you're a good orthodontist, so I can't do that easily. But yeah, TAD TPA or TADs in that posterior segment, but again, we have candidates this week saying, yeah, I'm going to take 6s out because they're poor prognosis, and I'm going to put TADs. I'm thinking, where are you going to put your TADs? Because you've got an extraction side. Yeah, if you put TADs and then extract the 6s, which I'll take the buckle in, and fracture the buckle plate with TADs plate. Somebody else said, I'll leave it for 3 months and fit my TADs. Well, your 7s are distally angulated. So in 3 months, they're now here, and you've lost half your anchorage. The best place to put a TAD to retain 7s is the palate, not the buckles. Or, if it's like that, you use it with zygomatic screws and can understand the vertical issues that that causes. Cause significant confusion. So here's a smile at the end with 6s and 4s. Don't think we've ruined her smile, guys, have we? And that's her occlusion at the end. The 8's dropped in at the back, that's the 7th, 6th position. May not be the way you would have treated it, you could have done a functional. Again, if you said a functional, it would not fail you. But if I said, what about the vertical, and you said, that's not a problem, I would fail you. I'm not worried about it. Yeah, I have significant concerns about the vertical here. I might have head plate or headgear to my twin block. I might make sure my 7s are covered to prevent over-eruption. I would keep a close review of my vertical during my treatment. I think that would be absolutely fine. I might say, well, do you know any other appliances that are less likely to increase the vertical? 11. I think we've got coffee. Yes?
I want to make sure that you use only TPA in the last case.
Yeah, so we used TPA, but I retracted tooth by tooth. Yeah, and because my fixed appliances have been used first, so if you're taking out 6s and your 7s are like this, do a sectional fix first, upright your 7s, if anything, slightly distally incline them, and they are less likely to tip into the space. So before you take the 6s out, get your 7s upright. 7s come into the arch with their crowns distally tipped, their roots meeting it. So as soon as they have space, yeah, you can lose about 1/3 to a half of the unit very quickly, particularly in a high angle case. Angle cases lose anchorage quicker. So if there's a less bite force, the tooth is out occlusion a bit more, those teeth come forward. So I would always upright my 7s, put some anchorage on them, and then remove the 6s, rather than do it the other way around. But take the 6s out, then upright them, I've lost the space, and struggling. So prepare your anchorage in advance. Okay? And again, if you put your TPA on the 7s and then tipped and rolled, as you build up to your arch wires, TPA is fixed the teeth. You see that a lot. I'm putting a TPA on here. If you've got a crossbar, how are you going to cut your crossbar if you've got a TPA? You can't. It fixes your teeth where they are. So when you put a TPA on, if you're happy with the molar position, I might say to you, how effective do you think the TPA is? In a real clinical world, I think they're rubbish. I don't think they do very much for the AP anchorage. I think they're very helpful for transverse anchorage, but I would say they're pretty much useless. So I use TAD TPA. I'll have a tab in the anterior palate, and my TPA will come back. It's locked onto the tab at the front and popped into the 7. Let's break there for coffee. Let's just check coffee's outside before we do the mechanics afterwards. So let's just check.